Moment. I am Simon Rabinowitz. Some of you might not know me. I'm a pediatric gastroenterologist. I have been at Downstate Hospital at the moment. Prior to that, I was at Richmond University, and previously that was called St. Vincent's. I was, in fact, the chairman of pediatrics there for about 7 years. Before that, I was a consultant at Staten Island University Hospital. I started the pediatric GI service there, and I was there for just about 10 years. I was the originator of the pediatric GI service at the medical school in Brooklyn, so I've been doing this for a little bit of time. This concept hatched through the idea and through the tremendous amount of efforts by the Girardis. Just raise your hand so everybody can see. Nicole, and Anthony. And the fourth person who's up here right now is Dr. Mel Koplow, who is a pediatric videographer. You can find a whole range of topics at his website, DrMDK.com. And he has very graciously agreed to videotape it so that individuals who are unable to come or unable to have the whole thing will have an opportunity. We will have this made available to anybody who wants to see it. The general format of what we're doing is that we'll have a speaker every week. This one will be me speaking. I won't be the speaker every week, don't worry. And there will be always opportunity to specific question and answer for those things directed to the speaker themselves. The other portion of each meeting will be a generalized opportunity for the people who are here to exchange thoughts, ideas, experiences among ourselves. I'll be able to give whatever input that would be appropriate. If the situation were to be that we have so many people that one group, that's not the case today, would be unwieldy, we'll break it up and have perhaps different themes or different types of focuses in each little group in order to, again, fit everybody's needs. Today's talk comes from, it will be on eosinophilic esophagitis diagnosis and management. It's not my talk per se. I am a member of what's called the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition. It's a North American group of pediatric GI people. They have partnered with a research component of that group, as well as a independent group that's committed to doing research on eosinophilia. And the three collaborated together to put together the funding to create the presentation. I'm going to use the slides from that presentation, aside from three at the very end. And I thought that they were very important. In fact, my society has not really formally recognized this part about it, but I think that it's an issue that's unfortunately not adequately emphasized, which is how do the kids deal with the problem themselves, especially the ones who are in school. And the unfortunate truth is that oftentimes these kids are bullied as a consequence of their food restrictions. So I think that that's a very, very vital part of what we'll want to do, and so I'm going to be introducing that towards the end of the talk. The talk is really kind of an overview about the diagnosis of EOE, that's the short name for eosinophilic esophagitis, as well as an approach to the treatment protocol. Everything that we do here, and I will be having discussions with the other speakers, will be on the level of the patients and on the level of the parents. So it's not like this is supposed to be for the doctors. That certainly, without a doubt, I'm positive that there are a number of doctors who would benefit from learning the important components of what we'll be talking, but it will be presented in a way that's appropriate for all of you. And if there are things that you're not really sure about what the slide means or what the point I'm trying to get across is, videographer, so they'll all be available for viewing to those who come in a little bit later. All right, so this just says that all of this material is supported by the Children's Disease Health National Foundation, the National Society, and then some of the pharmaceutical companies have also provided. All right, so what is EOE? So it's both a clinical diagnosis and a pathological diagnosis, meaning that there has to be some clinical symptoms, and they vary from age to age. Little ones have trouble swallowing or eating, vomiting, and then as they get older, abdominal pain, heartburn, feeding difficulties, and actually food getting stuck. You need to have eosinophils. That's what the diagnosis, we'll get to what those are in a moment. And we take a biopsy, so then you understand that you are going to have a biopsy, and you count, and it has to be more than 15. And it has to be limited to the esophagus. And there has to be no other reasons for having this particular phenomenon, meaning the eosinophils and the symptoms. And it's important to know that in a way like food allergies, these are relatively new. When I was a kid, there was no such thing as somebody in the school with a peanut allergy. I never knew anybody who had that. Nowadays, the peanut allergy is so severe that you can't have a person on the other side of the cafeteria opening up a peanut butter sandwich. So is this really something that's new? Why was it not known before? What happens to the natural history? And that's going to be a guess. Why? Because it was only discovered in 1999, so it's only been 14 years. How to diagnose it, how to treat it, and how to monitor it once it's there. So, as I say, it's not really understood. So that means we don't know where it comes from for sure. There's a lot of ideas, and we're not certain exactly what happens. But what we do know is that certain patients, the esophagus gets so narrow that it can't allow food to go through. And when attempts were made to try to widen it, oftentimes the whole organ ripped apart. And as you can imagine, that's a total disaster. So this looked at 30 adults who were followed for 7 years. So for an adult, that's not very long, and for a kid, it's nothing. So if you're diagnosed when you're 5, we're not even talking about 12. So almost all of them had trouble swallowing. That's what dysphagia is. 1/3 of them wound up having so much narrowing that they needed to have the dilation. And it showed that there was scarring taking place. So what's the problem? The problem is this eosinophil. There are not supposed to be any eosinophils in the food pipe. Eosinophils are a normal cell. In the old days, they protected humans from worms and other kinds of parasites. They were cells that created a very robust and aggressive response to help the body defend itself. Once they go in a place where they're not supposed to be, it's easy to understand how they can cause a tremendous amount of problems. The little cartoon here shows that the antigen or the trigger comes down the food pipe. It can be swallowed, the food, or your deep breath, it goes down, some of it to the same way. Not all goes to the lungs, some of it goes down. And so either one, they get into the tissue, they lead to the production of eosinophils coming there. We're not sure why. And the eosinophils start a whole cascade, they call it, a whole series of secretions that lead to damage. the damage leads to the pipe, if you will, not working properly. Now, this atopic is another word for allergic, and allergy was seen to be an important part of this condition. So, rhinoconjunctivitis is runny eyes, runny nose. Over half the kids have it. Wheezing, the signal that you see for asthma, 1/3. A history of having some allergy to foods, almost a half. Somebody in the family having something like that, 3/4. So there is this idea that there is an inherited natural predisposition to it. But the small number of people who have it in the same family, they probably will have more and more, but right now it's a minority. Now, this shows you that as we're going from the 1980s to the 2004, and it's just continued to go up, the number of new cases is getting greater and greater and greater. Here we're looking and seeing that more and more new cases every year are being diagnosed. Now, it doesn't matter what the slide is, but the principle is that you see in the blue, in the corner to the right, and then on the left is the normal. People who have this have a number of different genes that are expressed, and then there's on the bottom, the yellow, a number of genes which are not expressed. So one can see that this is a very complicated disease. It's not, and again, this is a very busy, but it's just trying to give you a little insight that it's a complicated situation. Here you see on the left that there's food and breathed in aeroallergens that can trigger the important chemical that we know of, and there's probably going to be more, is called eotaxin. It's made by the eosinophils, and it causes even more to come. So then you have a one, winds up having many, many, many. And these cause the irritation, the inflammation, and then ultimately the potential for the narrowing and the dysfunction of the esophagus. Just again, the eosinophil is a cell that's in our blood, and the esophagus is the tube that goes from the mouth to the stomach. So there are a number of different parts that change the esophagus. They put scar tissue down, they make new blood vessels, and they set up an inflammatory, which oftentimes has to do with part of the symptoms. So the scarring, the fibrosis is a fancy word for scarring, definitely takes place in adults. There are a lot of animal models that they have that show it, and we definitely know that it also takes place in kids. What does the eosinophil do? The eosinophil is a cell, as I said, that protected our bodies originally from invaders, worms. It's also important for asthma, and it definitely causes destruction as it tries to rid our body of whatever it is that's causing the problem. So how about some of the features? So it happens to be more common in boys, 3 times more than girls. There have been families, although as we see it's a very small minority right now. It's definitely associated with food allergy, and if you have it and you truly have it, then it is a chronic condition, and it has to be thought of in that kind of a way right now. We don't have a cure. We don't have a cure for diabetes. We don't have a cure for asthma. We have a cure for strep throat. So we need to think about these conditions in an appropriate way as far as having the best outcome for the kids. So if you see here that the age is on the bottom, the little ones, they have trouble with eating. The school-age children have vomiting and abdominal pain. The junior high and high school kids have trouble swallowing, and then actually, as they get older in adolescence, the food actually gets stuck on the way down. And that's, of course, what we don't want to have happen. The pain is found in a variable number of kids. It's oftentimes absent. It could be chest pain, it could be belly pain, it could be both. Oftentimes the kids have symptoms that look like heartburn or reflux. Pain with swallowing is usually not there, but trouble with swallowing oftentimes is. I'm going to just go back for 1 second. I personally have had a lot of arguments with the national leaders in this condition. I oftentimes have utilized medicines that lower the acid level as part of my treatment for the kids with a substantial amount of success, and many of the people, in fact, felt that that was impossible. Using that word. The most recent guidelines actually amend that point and allow for that principle. So again, the example is nothing about me, but the idea that this is an evolving situation. We don't have the full picture yet. So vomiting, some people say very few, some people say almost all. There's nothing special about the vomiting here. It's usually where they have vomiting, where they really are retching, as opposed to just having it just spit up out their mouth. And it doesn't necessarily occur immediately after you eat the food that you're worried about. So you don't want to get confused thinking that. Swallowing, which is the problem for the older kids especially, and little kids it's not as evident. But little kids have choking, have gagging, and don't want to eat. That's what's the most common way. The bigger kids will tell you that food gets stuck. One of the questions that I ask, and a lot of times the kids themselves say yes, do they have to drink a lot of water or liquid to help the food go down when they're eating? So that's one thing to be watching and seeing if that occurs. And then ultimately the idea of the food getting stuck. So this is when I do the endoscopy. This is what I can sometimes see. You can see there are rings going around. That's the scar tissue itself. This is an interesting phenomenon, is that usually when you have a scar formation, you usually think that's permanent. But fortunately, a lot of the scarring is able to be reversed. And we're not even fully able to, even the scientists aren't even fully able to explain that. But you can see from the left all the different circles, and on the right, are they totally gone? No, but you can envision how they're so much better than what they were. On the left, so sometimes I'll come out and tell the family, you have it. How do I know that? Because I actually see these white spots. These white spots are collections under the microscope of hundreds of eosinophils. So that's an indication that the disease is there and significant. This is these rings. The rings get smaller and smaller and smaller and ultimately get stuck. The tissue, because it's so irritated, is very fragile. This isn't me. Somebody else looked down, and literally part of the pipe sheared away, just like you took a lining of something and you ripped it apart. Again, this is where it just shears apart. So atopy is another fancy word for allergy. So we're going to look at that connection there. So asthma, allergic rhinitis, runny nose, atopic dermatitis or eczema, and food allergies, they're all increasing in the general population. The eosinophilic esophagitis is exactly correlating with this. Much more patients, if you look at the general population, and then you look at the kids with the EOE, it's eosinophilic esophagitis, that's the abbreviation, much more allergy in that group than in the general population. So here you see these are 4 different groups, and you can see the top is in the general population, and you can see that asthma, a half or 2/3, runny nose, almost everyone, and at least this 1/3 group in Australia, and then the eczema, again, from 1/4 to 1/2. So all of these things run together in the same circle. So overall, in the United States, it's now felt closer to the 8% of all kids have food allergies. 3% is going to be diagnosed even little, toddlers, 3 or younger. The majority of the kids who have EOE do have some foods, and they will improve when you take that food out of their diet. We'll talk about that in a minute. You also have the breathing in can cause the same thing. And we see that there are allergy seasons. And we see that allergy seasons also correlate with eosinophilic. Okay, so this would be a time when you'd expect the kids to have a little bit of an issue. So one thing that has some similarity is heartburn or reflux, and it's important to try to distinguish. So the symptoms in EOE are once in a while. The symptoms with the reflux are more common to be taking place on a regular basis. You can measure the acid. In EOE it would be normal, but in the reflux it's abnormal. If you gave the acid blockade, they say unresponsive. I disagree. But certainly for the heartburn kids, definitely it helps. Endoscopy, because it's a diagnosis based on the finding of a cell, you need a biopsy, so they have frequent endoscopies, and the determination of more than 15 EOs is required. So separating the two, and this is now coming along the lines of what I've said, is probably a little bit of an oversimplification. Because when the esophagus is not working properly from the EOE, the likelihood of acid coming up is higher. So now you have the EOE kid who also has problems from the acid. And no matter what you do with the food, if you don't do anything about the acid, he's still going to have symptoms. And if you treat the acid, even before you wind up determining what all the foods are, the kid is going to feel better just from not having that bothering him all the time. So think about the worst heartburn that you've had. Think about a little kid having that all the time. So what the recommendation is now is that to give a strong medicine for the heartburn called a proton pump inhibitor to help make the diagnosis. And then this just looks at some of the comparisons. It's important to understand that even though these are different numbers, most of the things that they use to characterize the eosinophilic esophagitis are also there in reflux. They're not there as commonly, but for the kid who has it, they're there. And so the artificial site that this is nothing to do with the other, again, I don't really follow that fully. So acid suppression, it's called a proton pump inhibitor. It's helpful to make the diagnosis. It's helpful to treat the reflux symptoms. And I certainly think, in the old days, since I'm old, they used to find eosinophils, and they said if you had an eosinophil, then you had reflux. That's, when I was in training, that's what they used to say. So now they've come full circle to say that if you have eosinophils, then you probably don't have reflux, you have this. So how about all these people that were being treated for 20 or 30 years? All of them were wrong? Logically, that's where some of these things don't always fit in together for me. All right. I've had people say to me, how come it takes longer for you to do the procedure than somebody else? Because they've been to somebody else before. And this is sort of the reason why. So this is the number of biopsies. So on the far left, you have 1, and going up to higher numbers. You'll see the orange bar, you're going to get to about 95%. So for me, I'll usually take the 3 pieces of tissue. Why? Because if you miss, and 1/3 of the time or 1/4 you're going to miss, who are you doing anybody a service to? You put the kid asleep, you've done the whole investigation, and then on top of everything, you come up with the wrong analysis, and then something that the kid is not really ready for, you make a change based on that. Ultimately, the child is going to come back worse off, and then they wonder why. So adults, fortunately, are much more likely to require the dilation than the kids. And it says here that a number of patients in this group had the dilatations. The first studies, several different people, showed that a lot of times when they tried to dilate, means stretch out, when they tried to dilate, the whole tissue, which was inflamed already, ripped apart. And you can imagine not having the way to get from the here to there causes a tremendous kind of a problem, and there's no such thing as a transplant of an esophagus. Whatever you're going to do will never ever work. So that's a consequence that we want very, very much to avoid. And now they understand that if they treat before they put the balloon in, it's much better because they bring down the irritation, and so the tissue can take that stretching a little bit better. But you see, the bottom part is that if you wind up getting it, half the time you're going to keep coming back to get it more and more. So it's important to know that for that child or teenager or adult, even though you dilate it open and the food can come down, you've not touched the disease itself. And so you have to work hand in hand with trying to identify what the problem is and make that better, in addition to at least letting the person be able to swallow. Okay, so now we're going to look at the various options that we have to treat this. So the first one in terms of order was steroids. It's the same steroids that they use in a lot of different conditions. It's not the same steroids as the adults use to make the athletes use to make the big muscle. These are an anti-inflammatory steroids. And this first report was, again, back in the 1990s. 20 patients. This is a high dose, 1.5 milligrams, and they all improved virtually. But everybody will have a side effect. Everybody is going to have a side effect. The longer you're on, the more side effects you have. The longer you're on, the more serious the side effects you're on. But if you're going to have 4 to 6 weeks, 4 weeks on, 6 weeks of lowering the dose, you're guaranteed that you're going to wind up with side effects. I'm not saying that nobody should have them. I'm just saying that the doctor should alert you to what is going to be occurring. But it's very effective. As you can see, this is the eosinophils before, and there's hardly any after the treatment. It's the most effective treatment of all. Now, then they start to say that the same inhalers that are commonly used in asthma, maybe instead of puffing it so it goes into the lungs, maybe just swallow it and then it goes down into the food pipe. And that was shown to be effective. They compared it and they showed that a number of kids here, not as good, but almost as good as taking it by the mouth, and many, 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 many fold fewer side effects. So if you need to go, this certainly should be the first way that you'd think about going, unless there's been, for whatever reason, a very significant delay and there's very significant disease. So the problems with this approach is that every single Tom, Dick, and Harry has a different way to do it. And so it's not like everyone has the same dose of prednisone for asthma. Everybody has the same dose of penicillin for a strep throat. So there is a little bit of variability to what is utilized. Of course, it's the same concept. The higher the amount, the more likely it is to be effective, the more likely you are to have a side effect. So your doctor is going to have to be able to explain what the situation is. Here you can see that with the blue line is the oral and the yellow line is the inhaled. It's both pretty good. Now, it's important to look at, these were all treated for the first 12 weeks, then they stopped. And you see that as the next 12 weeks go by, which is what, 3 months, you're starting to see almost half, 1/3 of the patients start having symptoms. So steroids are good, but again, one has to understand that in a chronic situation, you want to do something that's going to be able to be done for a long time, not a short time. There is a different form than the fluticasone. It's called budesonide. It's, again, a swallowed one. There have been reports in adults where the kids, adults who failed the fluticasone have gone on to the this alternate without having to take it by mouth. I have one patient, teenager, college student, missed diagnosis, incorrectly diagnosed, incorrectly treated, incorrectly explained. When he came to me, he was a gigantic mess. So I spoke with him, spoke with the mother, and I have he goes upstate school. I have the pharmacy in the neighborhood of his school make it up for him. He's mentally strong enough, doesn't taste very good, but he does it. 1 shot in the morning, 1 shot in the evening, and that's the way he goes. All right, so the next way is by changing the diet. We said that it's to do with allergies, so what the idea is, take those out of the diet. So again, we see here before and after, it's very effective. There are certain general foods which are more commonly involved. Milk, egg, soy, wheat, beef, and they're giving you other ones here which are secondary. Most people, it's not just one, it's multiple. The average is 4 to 5. What's good about the diet? If you do it correctly, it's very effective. You don't have any side effects aside from the pleasure that one derives from eating a food that makes you feel bad. That's what it does. The other extreme is, and there is at least one person I'm aware of on Staten Island who is so allergic that they really are required to simply drink a nutrition that's non-allergic. Okay, it's very, very simple. It doesn't taste very good. Most people have a tube and they get it administered through the tube, but this boy from Staten Island will drink it by mouth. He drinks 8 boxes a day. He runs track. He is a great boy, and he is definitely has issues with dealing with the problem, and as I said, that will be one of the themes, but as far as his health is concerned, he is doing extremely well. These are expensive. These usually involve fighting with the insurance company to get them to remunerate. Then there's sort of a third approach, which is to take the individual and determine what are that child's individual allergies, and there are various tests that are able to be done. So one approach is just to eliminate the most common one, milk, soy, egg, peanut, wheat, fish, and the other is to look. So if you eliminate all of them, so of course that's simpler, you don't have to do any testing. You run the possibility of A, you might be eliminating something that you don't need to eliminate, and B, maybe something else is a problem and you haven't recognized it. It is effective, fairly effective either way. The one where you have the steroids, like we said, was about 95. The one where you have that special drink is 90. And the one with the restricted is 75 to 80. And we just touched upon this already. So this looks and you can see that they're all relatively effective. Again, these are patients who are not getting acid suppression. In my group, they'll be getting acid suppression along with it, and they will be responding even better. Again, the same principle understood from a different perspective, that if you have the EOE and then you add back a food that you are allergic to, the disease will come back. Even if you've had, like in the blue, where it's totally gone, all the eosinophils are gone, all the symptoms are gone, you add back, it comes again. And here shows a different, the endoscopic improvement. Here you have on the top, the left is before the diet, in the middle on the diet, and on the right you add the food back, it comes back. So how do you test for allergy if you want to go that pathway? Meaning not using the steroids and not just eliminating the 6 food, but deciding for yourself what kind of foods. And one of the future speakers will be an allergist, specifically to expand upon this. But there are various tests. There's a prick test, it's called, a blood test, the IgE test, and it's a patch test. The prick test, again, it's as the name implies, you get a little prick, and the prick shows a skin reaction if you're pricked with the food that you have sensitivity to. A big test, a small test, it doesn't mean bad or worse. It's just general positive or negative, pregnant or not pregnant, not more pregnant, less pregnant, pregnant or not pregnant. So this is a device, so you have multiple tests get done all at once. This is the patches. Instead of having a prick, you take the food, that's the thing that you're testing, you smack it on the back, and again, you can see this poor boy, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12 different, and they peel off the patches, and they see what's going on underneath it. So again, we recommend the acid suppression, a strong medicine to see what happens, and then we all need to understand that this is an evolving situation, and it's important to understand, because the best person to decide for your child is you together with your doctor. So you want to eliminate the symptoms, allow the child to have a good life, a good quality of life, and you want to absolutely prevent the complications that could have an issue for the kid. Some people say we should get just no symptoms. Some people say we should have a perfect biopsy, meaning no more of the eosinophils. And some people say we should have the endoscopy return to normal. So for the people who say the biopsy has to be looked, they say that the biopsies, the eosinophils are destructive cells, and so it makes sense to get rid of them. However, you need to do endoscopies in order to know it. And there's no proof. We're just starting to understand. We don't know that if child A has eosinophils, that he's more or less likely to go on to the narrowing and the stricture than child B. We don't know that yet. So causing a general application, maybe it's the right thing, maybe it's not the right thing. Again, the principle that in a condition where things are changing, it's going to put a little bit more of a burden at trying to follow a little bit more carefully what the individual situation is.